Parathyroid glands, pages 453 to 456 in the PET-CT textbook. Parathyroid glands are located in the neck. They are multifocal, there's usually 4 of them. They're found alongside the thyroid gland, lying either adjacent, beneath, or within the substance of the thyroid. Parathyroid glands migrated from their embryological origins in the branchial clefts into the neck to their usual location along the thyroid. They can be found within the thyroid gland, elsewhere in the neck, in the mediastinum, within the thymus, or along the great vessels, which is within the carotid sheath, above the level of the thyroid, to the area around the subclavian, vessels in the thorax. The parathyroid glands synthesize, store, and secrete parathyroid hormone, which is a polypeptide hormone that regulates calcium and phosphorus metabolism through action on the bone, kidney, and GI tract. In the bone, parathyroid hormone directly stimulates osteoclastic activity, increasing bone resorption and thereby making calcium, and also phosphorus, available to the plasma and tissues. In the kidneys, parathyroid hormone increases urinary excretion of phosphorus by inhibiting tubular absorption of phosphate. In the GI tract, calcium absorption from the bowel lumen is enhanced by parathyroid hormone. Synthesis and secretion of parathyroid hormones are regulated by the plasma ionized calcium level, which is maintained in a physiological range by means of a negative feedback loop, which means that a decline in plasma ionized calcium stimulates the release of parathyroid hormones and makes the calcium ion available. The failure of the parathyroid tissue to produce parathyroid hormone results in hypoparathyroidism, causing a gradual reduction in serum calcium, also called hypocalcemia. Clinical manifestations of hypocalcemia are a consequence of delayed repolarization of cell membrane electrical potential, which results in muscle spasms and irritability, as well as cardiac conduction abnormalities. Excessive secretion of parathyroid hormone is called hyperparathyroidism. A principal component of this disorder is elevation of the serum calcium, called hypercalcemia. This is associated with increased urinary excretion of calcium, which can cause renal stones and calcifications of the kidney, as well as other soft tissues. Because the bones provide a storage source for calcium, orthopedic complications arise from bone mineral loss. Hypercalcemia has many causes, including primary hyperparathyroidism, renal disease, sarcoidosis, and metastatic bone disease. Here I provided an infographic chart that compares primary, secondary, and tertiary hyperparathyroidism. It gives you a quick source of comparing serum calcium, phosphate, and PTH. Primary hyperparathyroidism is most frequently associated with a functioning parathyroid adenoma arising from one of the parathyroid glands in about 80 to 90% of the cases. Hyperplasia of the parathyroid glands accounts for the remaining 10 to 20% of the cases. The underlying mechanism for diffuse hyperplasia with loss of normal feedback suppression is unknown, but the condition is probably a result of receptor autonomy. In chronic renal disease, the kidneys fail to excrete the phosphate ion adequately, and serum phosphate levels rise. Because an upper limit exists for the product of serum calcium and the phosphate ion concentration, calcium is deposited in soft tissue or is excreted. Lowering of the serum calcium in this manner stimulates parathyroid hormone secretion and parathyroid gland growth, leading to a clinical condition known as secondary hyperparathyroidism. Therapy should be directed to the underlying renal disease. At times, the hyperparathyroidism and related hypercalcemia are so severe that a transplanted kidney would be at risk. Surgical removal of the excess parathyroid tissue is also necessary. In the modern era, routine serum calcium determination results in earlier clinical recognition of hypercalcemia, thus leading to earlier detection of hyperparathyroidism. This presents an opportunity for nuclear medicine to assist in the localization of the function of adenoma because with earlier recognition comes the challenges of locating smaller adenomas. So to do this, we'll need some radionuclides. MIB has emerged as a radiotracer of choice for localization of parathyroid adenomas, also called sestamib, is a lipid-soluble radiotracer commonly used for myocardial perfusion scintigraphy. It distributes proportional blood flow and is rapidly excreted and past the cell membrane, binding to mitochondrial proteins. Because the thyroid is a metabolically active organ, rapid and vigorous thyroid uptake of this tracer occurs, followed by slow washout over hours. MIB is commonly used in parathyroid adenoma localization because it is vigorously extracted by both thyroid and parathyroid tissue. Detection of abnormal parathyroid tissue is possible because it washes out of normal thyroid tissue more quickly than does abnormal parathyroid tissue. We have two different methods for parathyroid scintigraphy. They're referred to as the dual phase method and the dual tracer method. In the dual phase method, you will use sestamib, 20 to 30 millicuries, and in the dual tracer, you use two radiopharmaceuticals. You can use sestamib in order to identify abnormal parathyroid tissue, and either pertechnetate or sodium iodine, I-123, to identify thyroid tissue. Subtraction imaging methods are used in the dual tracer method to differentiate between thyroid and parathyroid tissue, almost like subtracting background. In clinical situations in which hyperparathyroidism is suspected, direct measurement of serum parathyroid hormone by radioimmunoassay provides the basis for the diagnosis. The role of nuclear medicine in patients with confirmed hyperparathyroidism is an effort to identify the location of the parathyroid adenoma and not for all the differential diagnoses of hypercalcemia. Although surgeons are great at finding and removing parathyroid adenomas, being able to localize the adenoma in the first place prior to surgery really increases the chances of improvement for the patient because they are spending less time under anesthesia and on the operative table. There are other modalities that are great at locating adenomas. They can't really provide the same information that a nuclear medicine scan can. Parathyroid scintigraphy itself has a high degree of accuracy, and this introduction of the gamma probe provides assistance in site localization within the OR. It also serves in confirming the completeness of the resection. The two methods are currently available are the dual tracer and the dual phase method, as we recently mentioned. In the dual tracer technique, you're using between 2 to 10 millicuries of TEC to identify thyroid tissue. Subsequently, 20 to 30 millicuries of MIB is administered to identify both thyroid and parathyroid tissue. Both image sets are corrected by background subtraction. Pertechnetate image is denormalized to the MIB image by adjusting for the ratio of counts in the thyroid region of interest, and then normalizing pertechnetate image is subtracted from the secondary acquired MIB thyroid and parathyroid image, thus effectively leaving the residual image representing parathyroid tissue. This process is used to involve operator interaction. Thyroid adenomas and thyroid carcinomas are frequently false positive findings because these tumors trap pertechnetate poorly and therefore appear as cold spots on the images. Even with this knowledge, thyroid adenomas and carcinomas cannot readily be distinguishable from parathyroid adenomas by subtraction imaging. In fact, the situation is the same as the flip-flop phenomenon described for different diagnoses of thyroid nodules. The use of MIB has, in general, supplanted the use of thallium. Previously, when thallium was used to identify parathyroid adenomas, I-123 was used for subtraction of thyroid tissue. Some departments continue to prefer I-23 for thyroid localization. Although good quality images are obtained, images cannot begin until 4 hours after I-123 is administered. Other tech tracers that are introduced for myocardial perfusion images have been used in place of MIBI in both the dual tracer and dual phase parathyroid scintigraphy for identifying adenomas, such as tetraphosmin. They have extraction efficiencies and washout rates that are slightly different from MIBI. Although they provide satisfactory images, they have been obtained in many instances. The few comparison studies available suggest that MIBI is superior to its competitors to localized parathyroid adenomas. Here we have the parathyroid scintigraphy information on the indications, equipment that you use. You're using a gamma camera with low energy, high resolution collimators. I'm going to administer 20 to 30 millicuries of Tec-Cestamib via IV. There is no special patient preparation for the study. The patient should be positioned supine with the head and neck hyperextended to obtain a clear view of the neck. Acquire 10 minutes of static images of the head and neck, including any mediastinum, at 10 to 30 minutes after injection, which is called the early phase, and then again at 1.5 to 2.5 hours after injection, which is the delay phase. SPECT imaging is performed after each static image in the early phase and the delay phase. The SPECT images should be acquired over a 360-degree arc with 120 projections at 15 to 25 seconds per projection. Each SPECT scan can take about 25 minutes. To process, you want to subtract. To complete the subtraction, processing should be performed when using the dual isotope method. SPECT and SPECT-CT images should be processed according to your protocols. For dual phase studies, early and delayed image sets should be compared for visual differences. Sensitivity and specificity of MIBI subtraction scintigraphy are superior to that of thallium subtraction scintigraphy. The improvement in overall accuracy of the results of superior imaging characteristics, such as lower energy and greater photon flux with a larger dose and shorter half-life of TEC. Perfusion agents bind efficiently to mitochondrial proteins, resulting in greater parathyroid to thyroid, as well as parathyroid to background ratios. Dual tracer subtraction parathyroid scintigraphy methods depend on acquisition techniques and processing. The dual phase method depends on qualitative interpretation of the degree of contrast, which varies from adenoma to adenoma. Overall, this technique has an overall sensitivity of 91% and 99% specificity. Here we have some images when we use different tracers to look at the thyroid as well as parathyroid. SPECT images further provide improvement for surgical location of the hyperfunctioning parathyroid tissue. The sensitivity of MIBI SPECT is greater than planar acquisition and is helpful when detecting adenoma smaller than 1 gram. SPECT and CT fusion have provided high accuracy of location of the functional activity as well. Parathyroid scintigraphy has undergone a recurring cycle of technological advances. Many surgeons have adapted to using intraoperative probe guidance in addition to scintigraphy to help decrease morbidity and parathyroidectomies. Approximately 50% of endocrine surgeons use a gamma probe to perform minimally invasive parathyroid surgery procedures. The probe is used to enhance the location of the parathyroid adenoma and to confirm that all the hyperfunctioning tissue has been resected. We continue to use this, and it has been very helpful in localizing adenomas. Here we have some images of what a normal parathyroid scintigraphy looks like. I'm using Cestamib, and it's a little blurry, but you can see that it goes from 30 minutes to 2 hours. And we have anterior and Right oblique.